I'd like to thank the organizers for the opportunity to present our research about the evaluations of radiotherapy applied to preclinical tumor models using oxygen-enhanced EPRI MRI. I'd like to first start by acknowledging some conflicts of interest, but also to show that our research program is interested in biomarkers of the extracellular tumor microenvironment. That includes hypoxia and oxygenation of tumors. Also, it includes tumor acidosis or pH, enzyme activity, and vascular perfusion, which are interrelated in the tumor microenvironment. And to study all four parameters requires a multimodality approach. You can see a number of traditional imaging modalities here, including some chemistry and radiochemistry. And I'm excited that EPR imaging is poised to join that collection of imaging modalities to study the tumor microenvironment. I think we're at an exciting point in the development of EPR imaging. I'd like to give a rationale for why molecular imaging will make an impact in healthcare. I work in a cancer center, so I'll use cancer as an example, but this paradigm applies to all pathological tissues. So prior to diagnosis, we have many subjects, about 7 billion people in the world. And once they are diagnosed, then they become a patient. They can undergo treatment. Hopefully, the cancer then undergoes remission. But unfortunately, on occasion, it does recur, and we have to then go back and retreat the tumor. I think molecular imaging is going to have its greatest impact by predicting what type of treatment will have the greatest effect on the tumor, or to see early response from the treatment so that the patient can continue on that treatment if it is effective, or to discontinue that type of treatment very early on in the treatment regimen and get on to a different treatment that might work better. And the reason is because I really define the value of molecular imaging as being a ratio of benefit to cost. And molecular imaging is a very costly method compared to anatomical imaging or functional imaging or other non imaging diagnostic methods such as genomics, proteomics, blood sampling, and so on. And because of that high cost, it seems challenging to apply molecular imaging to screen a very large number of patients. Really, we have to be farther down in this pipeline where there are fewer people to be imaged. And it'll have the greatest benefit just before applying an expensive treatment to a patient. So, by predicting or looking at the early response around the treatment, that's really going to drive this value. Another way of looking at this proposition is to consider that patients can be easy to treat and are low cost, or difficult to treat and are high cost. And the difference between the price of the therapy and the average cost really does drive a hospital to make some decisions. Drives our healthcare market. And so the key is not to change these prices or costs. Although, if you could, that would be great, but they are relatively fixed. Instead, if we could remove the non-responders from this equation, those are the costly patients, and get them onto a treatment where they can respond, well, that will really drive down the average cost and really drive down the cost of healthcare. Hopefully drive down the price as well. And so I like to think of these non-responders as false positive patients. We thought they would respond to the treatment, but they did not. And false positives are related to specificity. So it is specificity that we need to improve. And molecular imaging is ideally suited to look at specificity. As you may know, anatomical imaging doesn't do a great job of getting specificity in the diagnosis. It's more for sensitivity. So I'd like to describe multispectral optoacoustic tomography and some studies we've been doing with this modality as a way of setting the table to describe why we need to go to EPR imaging in this multimodality paradigm of looking at the tumor microenvironment. So if you'd bear with me for a few slides, I'd like to describe a different modality to show how it's related to EPR imaging. We use a near-infrared laser to have light be absorbed by certain molecules in the body. Those molecules then undergo thermoelastic expansion, or sort of a macroscopic breathing motion, which generates ultrasound waves which are detected by an ultrasound signal detector. While there are great imaging characteristics with MSOT, it is limited to a 3 centimeter depth of view, which is a problem when it comes to clinical patient imaging. And EPR imaging has an advantage that, if done right, we can get through a deeper set of tissue. So here's a picture of the small animal setup, a 270-degree ring detector that fires in the laser and detects the ultrasound. Here's a clinical instrument using an ultrasound transducer probe that has a laser built into it. This is not an anatomical imaging modality. You can see the images are somewhat fuzzy, but by taking multiple wavelengths, we can construct a spectrum and do spectral unmixing to identify molecular components, which is shown here. Just one wavelength doesn't really provide much information, but multiple wavelengths does pick up molecular signatures within the body. So I really want to focus on this MSOT method to show this oxygen enhanced paradigm, which we're then going to apply to EPR imaging, where we have a mouse breathing in 21% O2, medical grade air, collect spectra at different absorbance wavelengths, get the experimental data spectrally unmixed to get the oxy and deoxyhemoglobin components, and then measure percent SO2. And we can repeat that with 100% oxygen gas for the breathing inhalation and get a percent SO2 there. We could take the difference between those two, known as delta SO2, and I'd like to briefly describe the biological context of delta SO2. As an analogy, if I'm driving in my car and I see that the gas tank is a quarter tank full, it is also 3/4 tank empty. So it has a remaining gas capacity of 3/4 of a tank, normalized to the size of the tank. On the same way, if I then fill my mouse with as much oxygen gas as possible, well, that is the maximum gas tank capacity of O2 within the tumor. And so I can measure this remaining oxygen gas tank capacity within the tumor. We did a study with a normoxic, mildly hypoxic, and hypoxic pancreatic tumor model, subcutaneous flank tumor model. By the way, Colo 357 was discovered at the University of Colorado, and so therefore is a pancreatic tumor model that has an unfortunate name that makes it sound like it's colon cancer, but it's not. And by doing our OE MSOT measurement before and after treatment, we can see a change in the percent SO2 with medical grade air and 100% O2 and the delta SO2 that's calculated. I really just want to focus on these graphs on the right rather than the raw data, which shows that prior to treatment, the normoxic, mildly hypoxic, and hypoxic models do show a percent SO2 that's high, medium, and low as expected with either gas, and also the delta SO2 oxygen capacity measurement shows that trend as well. Normoxic tumors have much greater capacity for getting more oxygen, while hypoxic tumors are pretty much maximized in how much oxygen they can have. So changing the gas really doesn't have much effect on them. After radiation therapy, it's difficult to see the pattern in this data, but what's key is that after radiation therapy, the normoxic tumor is affected by radiation and sees a significant decrease in this oxygen gas capacity. The mildly hypoxic model is somewhat affected by radiation therapy and sees a moderate effect, and the hypoxic model is not affected by radiotherapy and therefore sees no effect. The amount of oxygen capacity does not change. So this oxygen capacity, or delta SO2 parameter, is important for looking at the early response to treatment that we can't see with the percent SO2 by itself. Also, as another major key, we're studying the vascular hypoxia, the amount of oxygen bound to hemoglobin in the blood vessels. EPR imaging has the advantage of looking at the extracellular, extravascular tumor environment, and I'll point that out again a little later. So as yet another dimension to the study, we applied a radiosensitizer, TMX. 3 hours later, we applied 10 gray of radiation. And you can see that there are trends in the percent SO2 with air or 100% oxygen, or this oxygen capacity parameter. Also in the same study, we were able to inject a dye and calculate how fast that dye perfuses into the tumor or out of the tumor. This is done all in the same study, which is an advantage of the MSOT, that we can measure vascular perfusion and hypoxia at the same time. And the key here, just by color coding, is that the green data is from the normoxic tumor model, the red data is from my hypoxic tumor model, HS766T, and the blue data is a hypoxic tumor model that was treated with TMX. Of course, the green and red were not treated with TMX. You can see in each case, the green and blue data show similar trends, while the red data is always different. indicating that the TMX radiosensitizer essentially turned the hypoxic tumor model closer to a normoxic model, which is good for the radiotherapy, of course. So let's switch over. Oh, and one other major point. We did not detect an increase in oxygenation within the tumor from the radiosensitizer, which is intended to reoxygenate the tumor. And again, we're studying vascular hypoxia. This radiosensitizer produces oxygen within the extracellular, extravascular environment. So we don't see this burst of oxygen from the radiosensitizer, a detriment of this particular modality. So in EPR imaging, we're using a GV25 instrument from O2M Technologies in Chicago, Illinois. We're really enjoying the use of this instrument. We use OXO71, a tridal radical that is sensitive to PO2 as measured by the R1. By calibrating the R1 now relative to oxygen, now we can just perform a T1 inversion recovery experiment and an IR spin echo experiment. The rate of relaxation is related to the PO2. Now, there's very little concentration dependence here. Also, we have designed our experiment so that we hope to have a relatively stable concentration within the tumor during our measurements. And so, therefore, we are measuring PO2 in the tumor. Just to show some photos, we have a GIVA25 EPR instrument within an unused MRI magnet bay, so it is isolated from the radio frequencies from outside the room. Also, we have a workstation area just outside the EPR imaging area. And then on the other side of this workstation area, through another window, you can see the MRI scanner or the MRI magnet. And so we're able to place a mouse within a customized cradle, perform MRI, and then without taking the mouse out of the cradle, immediately put the mouse into the EPR instrument to do EPR imaging. Or we could switch and do EPR first and MRI second. Instrument is relatively easy to acquire data. We do pre-calibrations before actually getting the IRSC measurements, of course. And also it has an outstanding physiological monitoring system, which is critical for ensuring all the mice are under the same status when we collect our data. Then we perform EPR MRI registrations and segmentation and get out the PO2 measurements just of the tumor, which is outstanding. So in the CPR MRI study, we've got plans for an SU8686 model that's normoxic versus Decolo 357s. We first perform MRI under 100% O2 after some initial setup. We then wait for equilibration at 21% O2 and get our PO2 measurement. We actually repeat this a second time. The test retest shows excellent repeatability if the mouse maintains its physiology during consistent physiology. Then we switch over to 100% O2, wait for equilibration of that gas within the mouse, and then we get the PO2 measurement with 100% O2. By the way, we're injecting 70 millimolar of 300 microliters of the OXO71 intraperitoneally so that we have a relatively stable amount of agent within the tumor between 27 and 73 minutes. So as brief initial results, we see that the PO2 does increase when we change to 100% oxygen gas. This was a 4T1 model, it's a very preliminary study, and we see that there really isn't much change in the delta PO2. There's not much remaining gas capacity, which is expected for this tumor model. Also, pre-irradiation and post-irradiation data also show that there's an increase in 100% O2 breathing gas. The results are a little variable in terms of delta PO2, where there's a decrease in some animals and an increase in others. And we're following up on this on more mouse models or more mice, and also starting the Colo 357 part of this study. So we have the paradigm worked out. Now it's just a matter of acquiring the data and determining how delta PO2 can measure the effects of therapy. Finally, I just want to show that this radiosensitizer does improve tumor control with immunotherapy. So this is yet another paradigm where EPR imaging could be used to identify hypoxic tumors that should be treated with a radiosensitizer to improve the response to immunotherapy, not just radiotherapy. In this case, we've seen that TMX does increase the Oxygenation, the PO2 of a tumor, if the tumor is initially hypoxic. If the tumor is relatively normoxic, it has no effect. And so here, EPR imaging could be used to identify hypoxic tumors, predict that they should be treated with a radiosensitizer prior to immunotherapy, which would be a game changer in the clinic. With that, I would just like to thank the colleagues who I work with, including Tian Li, who was instrumental in getting the Jiva 25 working in our laboratory, along with our colleagues at O2M Technologies. And with that, I'd like to stop there and thank you for your attention.